Okay, thank you very much for this opportunity. Good afternoon, colleagues. This is my first time to serve at this level as a rapporteur for the Models of Care and Programs theme. I've analyzed 89 submitted abstracts, posters, oral presentations, workshops, and discussion spaces, indicating both established research and emerging innovations. I've identified key trends and innovations shaping our field. This analysis reveals both the maturation of our evidence base and exciting new directions that reflect our community's adaptability and commitment to people who use drugs. The submission spanned 4 main themes, and these are the community and peer-led models of care, the integration and decentralization of services, the digital and outreach innovations, the equity and access for key populations. Together, these reveal a shift towards flexible, trust-centered systems that reach people where they are. Community leadership is the beating heart of innovation. We see this in the United States, where the University of Kentucky Harm Reduction Hub has embedded peers into academic clinical partnerships to improve outreach. We see it also in Armenia, where needle and syringe redesign projects used peer consultations to improve service uptake. India also has decentralized hepatitis care through community partnerships, reaching prisons and underserved zones. These examples show peer leadership as both a delivery and design principle. HCV elimination strategies mentioned in various abstracts aren't just treatment programs. We are seeing innovative self-testing in Indian prisons using drones, community-led design in Armenia and Georgia, and point-of-care integration across diverse settings. Community-led research is moving from aspiration to implementation. We are seeing genuine community ownership of research design, not just consultation. The needle syringe programming work in Armenia and Georgia exemplifies research by communities, not just on them. Abstracts reveal that success often arose where communities were trusted to lead. Several models demonstrate that integration isn't just efficiency, it's equity. In Tanzania, Women Support Group integrated TB and HIV prevention into harm reduction sites. And in Australia's North Coast Health Hub, they blended opioid treatment with social care and mental health support. And in Canada, Siokuna, sorry if I'm not pronouncing that properly, they introduced nurse-led clinics within shelters. Across these, task shifting and service location reduced stigma and improved continuity. Peer-led models, integrated care, and population-specific interventions demonstrate sustained attention to core harm reduction principles while broadening their application through integration and task shifting. Many abstracts, many discussions, many posters, and all the other stuff that's been happening here actually highlight the decentralization access through outreach and mobile units. We see this in Yuba, Harm Reduction Collective in California, described mobile partnerships that move care across counties. Scotland's Highland Services tested micro-hubs in rural communities. And in Nepal, their field-based delivery of OAT brought care directly to service users without fixed clinics. Added to this are the many success stories from Africa shared during the community day, if you attended one. We can see that these models expand reach by moving beyond the clinic walls. Digital strategies are quietly transforming harm reduction. For example, in Ireland, they piloted an outline peer chat system for overdose prevention. In Kenya, they have an e-care platform linking hepatitis testing data across rural clinics. And in Australia, they saw an integration of telehealth into methadone supervision. So we are saying that our implementation science isn't just about having good ideas anymore. We are rigorously evaluating what works, how to scale it, and why some interventions succeed while others fail. This represents our field's scientific maturation. We are thoughtfully integrating telemedicine, mobile health, and digital peer support, not as emergency measures, but as permanent innovations improving access and engagement. Technology normalization shows thoughtful integration rather than tech for tech's sake. We are seeing evidence-based adoption of digital tools that genuinely improve outcomes, not just convenience. Technology acts not as a replacement, but a bridge between autonomy and accessibility. Geographically, this conference reflects growing global South leadership and increasing attention to low and middle income contexts. The mentions of indigenous approaches highlight culturally responsive care models that other communities can adapt. Importantly, we see women-specific interventions and sustained attention to marginalized populations, suggesting our field is genuinely grappling with intersectional approaches. We see this in projects from the Philippines, Mexico, and Brazil, where they are focused on gender-sensitive harm reduction for women who use drugs. South Africa's Step Up program, community-oriented substance use program, which is COSAP, TB, HIV care, and many others in Africa and beyond, are targeting women, youth, and homeless populations. Indigenous-led models from Canada and New Zealand emphasized cultural safety and decolonized care frameworks. Our research work shows that we are not just acknowledging stigma and discrimination, but we are developing systematic interventions to address them. Equity isn't an add-on, it's the measure of success. Our common challenges include funding instability for peer organizations, bureaucratic barriers to medication access, digital exclusion for older clients, burnout among frontline workers. There is low attention to mental health, suggesting that we need stronger integration. Yet abstracts repeatedly emphasized resilience and co-production. Relatively, few papers address policy and structural change areas for growth as we move beyond individual interventions toward systems transformation. Policy frameworks must also catch up with these grassroots realities. What are the emerging trends? Across the dataset, 3 strategic insights stand out, which are scientific rigor through implementation science, meaningful community engagement, and adaptive innovation. Also, methamphetamine-specific interventions are proliferating. We are seeing specialized approaches for stimulant users, including the fascinating work on collaborative strategies for people who use meth that recognizes the unique challenges of engagement and retention. There is a paradigm shift from delivering services to communities to designing systems with communities. And innovation flourishes when lived experiences lead. In summary, INHSU's 2025 Models of Care and Programs theme reveals a field that has evolved significantly. We are evidence-driven, yet community-responsive. We are innovative, yet grounded in harm reduction principles. The dominant HCV elimination focus, combined with strong peer leadership and emerging attention to methamphetamine and technology, positions us well for continued impact. Most importantly, this work demonstrates that our field maintains its fundamental commitment to the dignity and agency of people who use drugs while embracing the tools needed for elimination goals. Thank you.